Hello, everybody. I have right at noon Central Time, and let's go ahead and get started because we have a lot of material to cover, and I'm going to try to do this in 1 hour, so we got to move fast. Thank you for coming. This is the RHC cost reporting sort of year-end planning session. We're healthcare business specialists, and we'd like to thank our sponsors, Azalea Health and ChartSpan, for helping us to do this for no charge to you guys. So this is me. I'm Mark Lynn, CPA from Chattanooga. I've been working with the Rural Health Clinic program for about 35 years now, and there's my contact information if you need to get a hold of me. Dani Gilbert is here with us as well, and she has not been working for 35 years on RHCs, but she's fantastic anyway, and so there's her contact information as well. Here is all the services that we do. So if you need any help with any of these items, please let us know. We'll be glad to help. I won't go through them because, again, time frame. Facebook group. If you're not a member of our Facebook group, please join. We have about 2,000 members, and there's a lot of great information, a lot of great exchange of ideas, questions, updates. A lot of people participate, and it works really well. As a disclaimer, as you know, everything is changing very quickly in healthcare these days, and we've tried to keep this information up to date. I've been looking at everything, but there's no promises that something hasn't changed within the last day or last hour. If you have questions, please put those in the question box or in the chat, and Dani will read those off to me, and Dani and I will try to answer those at the end. We will try to open up the lines a little bit for you guys to ask questions as well. All of our sessions are always recorded. Yes, I did push the record button, so we're good there. These sessions are recorded, so you can watch those later if somebody else needs to watch it. They can do that. And your slide presentation, I've emailed that to most of you already. It is on our website as well, so you should have access to it. As far as an agenda, we're going to do a couple little updates. We'll talk a little bit about provider relief funds, and then we'll go into cost reporting. The first update is SE 216 was updated December the 3rd, 2020, the little red section here. They're going to reprocess your telehealth claims. They paid them wrong. I was pat myself on the back, but I noticed as soon as I saw some claims, I'm like, they're paying these wrong. And so the National Association of Rural Clinics worked very hard with a CMS. CMS said, no, we're paying it right. And they finally relented and said, no, we're paying it wrong. And what's going to happen is they're going to reprocess all of your telehealth claims. They're going to reprocess them. The way that CMS did it the old way was they took the telehealth rate of $92.03, and then they took your copayment, the 20% of your actual charges, and just subtracted that from it. So your payment was different. Your Medicare payment was different depending on how much the charge was. And so the way they should have done it was take 80% of $92.03 and paid you $73.63 for every claim. And then you guys would collect 20% of your actual charges from the patient. So your actual cash collections would vary. If you charged a very low amount, like over here on our first example, here's going to charge $50 for that G2025, then you would still get, in the old way, you would still get $92.03. It's just Medicare would pay you a lot more of that $92.03. And if you charge a lot, like if you're a provider-based RHC and you charge $150, then what would happen is Medicare would actually pay you less, and you would you'd still receive the $92.03 in this case. Under the new way, what's going to happen is you folks that charge a low amount, they're actually going to take money away from you, and you guys that charge the higher amounts, the $150, you'll be getting additional money back from Medicare. If you charged exactly $92.03 for your telehealth claims, then there's going to be no effect. And probably most of you guys will be in this range here in the yellow, where your average charge was about 100. You may get $1.60 per claim back. So those claims are being reprocessed, and they will not affect the copays, but it will affect the amount of money that you get. You'll be in the plus or minus range. CMS on Friday released, even though they backdated it to October 29th, they released the updated for your independent RHCs. The new capped rate is $87.52. So you should look for that increase starting in January of 2021. They should at least increase your interim rate to at least $87.52. If you're a Tennessee RHC, we did get some good news. Zane from TennCare sent me a memo on December the 7th. I guess it was an anniversary gift for my 35th anniversary was that day with my wife. So I guess that was our anniversary gift there. RHCs will get a 28.51% increase for all of your visits in January and February of 2020. I have no clue why they chose that period of time, but you are going to get an almost 30% increase there. The MCOs will be paying that. The key is do not report these payments as payments on your TennCare quarterly reports. If you do that, you basically you would net out to nothing. So Zane is telling us do not put those on there, and so we'll listen to what he says. So that's great news for you guys. So those are all the quick updates that we're trying to get to you. As far as provider relief funds, we wanted to touch on this for a few minutes because we're getting close to 12/31 and the end of the year, and there's a lot of requirements that you have. There's all sorts of intersecting sort of requirements that require you to take action. Number one, you got cost report issues that you have to deal with, federal taxes, provider relief fund reporting issues. You've got issues with the payroll protection, paycheck protection program, and productivity waivers. All of these, because of COVID and telehealth, is causing these issues with productivity waivers. Those are causing you to have to make decisions here. And I saw this cartoon yesterday, and I thought this sounds exactly like us. I live in each day, uncertainty forever, skating on the razor edge between cookie and no cookie, and that's your provider relief funds. You've got all this money sitting in your bank account. You have no idea if you're going to be able to hang on to this cookie or not, because they keep changing the rules on you, and it's very frustrating here. So somebody from the grassroots program with the National Health Association wrote this in an email, and I couldn't find it after that, but I thought it really summed up the way we feel. It's a grant that's not a grant. You must spend the funds to keep the funds, but if you spend the funds the wrong way, they're going to take it back from you. And if you don't spend the funds, you have to pay it back, including any interest earned. And that was pretty much a great summary of these provider relief funds and how frustrating it is and how often the rules are changing. And I looked up this word in constant, a synonym including fickle, wayward, capricious, volatile, flighty, erratic, mutable, mercurial, irregular. All of those really I can identify with those with this provider relief process. And what's this result in is you guys having so many questions and questions that I, for one, don't have the answers to. I don't think anybody does. I've been listening to webinar after webinar the last 3 weeks, the last 3 months about these issues, and I've really not got any good answers from anybody. So, some of the questions: how do I spend the provider relief funds? Will you be taxed on them? So how will it's going to affect your cost report? Will you have to pay those back? That's a big one there. And then what year-end steps should you do to minimize the financial impact? And that's one thing we're going to try to talk a little bit about as we go through here. And so you only have, and this slide I looked at yesterday, I copied and pasted it yesterday. We had 22 days yesterday. You have 21 days till year end to make some of these decisions. So we don't have a whole lot of time to sort of figure this out because you're going to be reporting your provider relief spending February the 15th, 2021. That's not that many. That's 45 days and 21 days. That's not that many days. And there's a lot of information that they're asking for you guys to put in this portal. The portal should be opening January the 15th, 2021. We've put together some information, a tool. It's an Excel spreadsheet. So if you click down here, you will be able to get this tool, Excel spreadsheet, and you need to start trying to pull the information together now. I won't go through the information today because that's not what we're talking about today. This just gives you some pictures of the sort of information you're going to be gathering, but you need to start looking at this tool and start gathering this information now. what we will do, and if some of you guys, if you want to send me the information ahead of time, we're gonna, as soon as the portal opens on January 15th, we're gonna take a couple of you guys and use them as sort of guinea pigs and go through the provider relief funds. And then we have a webinar scheduled on January the 21st, where we'll go through, tell you what we've learned about how to enter this information into the portal. This is dependent upon HHS actually doing what they say they're going to do, which is get this portal done by January the 15th. And so far, they've been sort of hit or miss on their dates on the portal. One thing that I think you can do now is, this will be the year where there's going to be no Christmas bonus this year, but they're going to be great hazard pay bonuses. That's what I would recommend to you guys is figure out a good hazard pay bonus program. If you've got that $103,269 sitting in a bank account that's not being used, if you don't use it, you're going to give it back to the government. You know, you've got your people that are risking their lives, and we've had providers pass away from COVID-19. We've had people get sick. We've got tons of people that have missed a lot of work because of COVID. And so I would figure out a hazard pay plan and try to distribute that money, because you're just going to give it back. And hazard pay is an allowable expense. So before December 31st, I would definitely be trying to spend some of that money in that form. So this will be my last slide on provider relief things and provider relief issues. Just some quick answers without context. Because the problem with trying to answer these questions is you go into lawyerese and it takes forever to answer a question. You can't get a yes or no answer about any of these provider relief funds, which I'm going to foolishly attempt to do. So should we try to spend as much of the provider relief funds as possible by 12/31? Absolutely, try to spend it. And what I would recommend, go to your banker while you still got that $103,000 in your bank account and ask them for a line of credit now, because if you do have pay this money back to HHS in July of next year, you'll have that line of credit already set up, just sort of as a safety net for this. Because you feel uncomfortable spending it, knowing that you may not get it, you may not be able to hang on to it, and I understand that. Number two, should we pay hazard pay to using my provider relief funds before 12/31? Absolutely, yes. And then do it again before June the 30th. June 30th, if you still have money left over from 12/31, you have until June 30, 2021 to spend that money. Will you have to pay back any? If you have those funds sitting in your bank account on June the 30th, you're gonna have to pay them back to the government. So my recommendation is empty that money out, find a good way to use it that will help your clinic. Are these provider relief funds taxable? Yes, as of right now, what they're telling us is they're gonna be taxable. What about your payroll protection program funds? Are those taxable? The funds themselves are actually no, but the expenses that you use with those funds, you can't deduct them on your tax return. So it is taxable, because you end up having that amount of less of expenses for that. So talk to your tax person about that, because I know you got some deadlines coming up for 12/31. Those will be important to talk about the provider, the payroll protection program. Are expenses reimbursed from the provider relief funds allowable expenses on the cost report? The way we're reading it is yes, they are. We get some conflicting information about it, but to give you the short answer, we're going to say yes. Are these answers subject to change? Absolutely. they change everything. Okay, we're finally getting to the cost reporting section. That only took 13 minutes, so that wasn't too bad. Cost reporting is going to be super challenging this year, and one of the reasons why we're doing this webinar is just to go through the process of us getting you signed up and preparing your cost report. First thing is, on our website at ruralhealthclinic.com, we have things called resources, and in resources we have resources on emergency preparedness, on billing, on I forget the other ones, RH. So we have one that's called RHC cost reporting, and this is where we're going to put all of our information related to cost reporting. These links will not work, so don't try to click on this. This is just a picture of the website right here. So, but that's where you want to go to get your information. And normally, what I always say is that it just seems like the year goes by so fast, and it seems like we just got the cost reports finished in May, and now we have to start back working on them again. This year is completely different, and we didn't finish working on cost reports till August, and it still seems like the longest year ever. And just for your enjoyment, that is a picture of me in grammar school, and I didn't wear the ties, but that is basically me in grammar school, because if you know me, I'm 6'9", so that's about, I can relate to this picture very much. So our client update, your cost report, your Medicare cost report, if you're a 12/31/2020 cost report, is going to be due by May the 31st. They've not changed the deadlines so far this year due to the PHE. That may change. That's subject to change, but as of right now, May 31st, 2021 is when your cost report is due. We are in the process of sending out agreements. We have like 175 people that are RHC cost report clients. We're sending out the emails with that. Also, there's a business associate agreement with that as well. If you haven't received one yet, you will be getting. Dani, can you give us an update on that process? Have you got them all out, or do you still have some more to go?
I still have more to go.
Still have more to go. Dani still has more to go. So if you haven't got one from us, you should be getting one soon. And if you don't get one within the next couple of weeks, then let us know, and when Dani will get out that business associate agreement. And there's a cost report agreement as well that basically says, here's what we're going to charge, and what we will do is we'll ask for a retainer up front, and then we'll balance bill the difference whenever we finish the cost report. But look for that. And then if we haven't done your cost report, if we haven't been doing it in the past, we still have some capacity, not much, but we still have some capacity. If you'd like for us to do it, let us know, and we'll be glad to get that information out to you. Here's the processes here. Number one is, first thing you'll do is sign that BA agreement and send us a retainer check. We will send you out a cost report checklist. I just finished it yesterday. It's 22 pages long. I'm sorry. It's only, the checklist itself is only 3 pages, but we put 19 pages of forms are in there that you can use that will help you get this information together. So once you get it, we want you to accumulate the information. Make sure that you can get your PSNR. There's a system called the EIDM system. It's the Enterprise Identity Management System. You have to be enrolled in that for you to pull your PSNR. You also have to be enrolled in that to make Dani a authorized Medicare cost report preparer to upload. If you want us to file your cost report electronically, and we will do this for some of you guys. If you've got EIDM and you can get Dani set up as an authorized cost report preparer for Medicare, we will try to file your cost report electronically. I think it's going to be easier for everybody because they've just added what's called bulk bulk cost reporting capacity. So people like us that do 175 cost reports, we can do it as a bulk filing, and we'll put everybody's cost report in there and submit it to them very quickly. So do that. That will be helpful. From Medicaid, we'll still have to file your Medicaid cost reports manually, and you will still get a manual cost report from us as far as the little leather booklet that has everything very neatly in there for you. We will still be doing that as well, even if we do file it electronically for you. And if we do end up doing yours manually on paper, you guys, we will send you a cover letter where the cost report goes to, and you will have to sign the cost report and submit that to Medicare. We do not mail off cost reports because we can't sign for them. You guys have to sign for them. So I've had people in the past where we'd send them the cost report and they think, oh, I thought you took care of all that. I'm like, well, no, the letter says you need to sign, and it's got a little sticky note on it here. We've got little sticky notes on there. So sign it and then mail it to the address that is on there. Once you file it, then let's go in here. I got a better, the next slide is better. So you have 5 months after your year end. So we have till May 31st to file this cost report. If you don't get it filed by May 31st, they're going to cut off your payments. And they're very quick about cutting them off and very slow about turning them back on again. So you don't want to be there. We will get your cost report filed if you get it on time, if you get it to us on time. We can't file it if you don't get us the information. And then the MAC is the Medicare Administrative Contractor. For most of you guys in our region, it's going to be Palmetto. And so they have 30 days to accept it. And then once they get it accepted, then they have 60 days to pay you a tentative settlement if one is due. And then from the time of acceptance, they have 1 year to final settlement. I must brag on Palmetto. They've been doing a very good job of getting these cost reports settled within that 1 year time frame and getting MPRs out. So we appreciate them working with us to get those done quickly. Now, this year it's going to be a little different as far as our cost reporting goes. We have a portal set up. We have a management system called Canopy that works great. And it has a portal that you guys, we're going to send you an invitation. The invitation will look like this, and we're going to ask you to upload your information through this secure portal. And so when you get your invitation, it's going to ask you to put in your first name, middle initial, and last name, put your email address in, create a password, and then once you do that, you're going to be able to see, this is going to be your view of the portal, and you can just put your files in here, upload those, and we will be able to see those and work with those. That is the easiest and the securest way for us to get your information. You can still mail it to us. You can email it to us. Just be careful about emailing PHI. Remember your flu and your pneumococcal logs, they're going to have PHI in there. Also, your Medicare bad debt listings are going to have PHI in there as well. So you just can't email those to us. You need to have password protected emails for that. So be careful with that. You can fax us information as well. We don't try not to fax it because faxes are really hard to read for some reason. Even though it's all done through the computer, they're still hard to read. But that's the process of us getting the information. Of course, you can mail it to either address. Danny's address is Cleveland. My address is Chattanooga. You can mail it to either one of those and it'll get to the right place. This is our website again, the resources there, and then these links actually do work. So if I clicked here, the 22-page PDF would come up. We also updated our RHC cost report count worksheet. It's now like 6 pages long, and we will go through that through this session as well. And there's some stuff on MCReF and other things which we won't go through as well. This is the first page of the checklist. We've just got some basic information on how to get a hold of us and some of our resources. And then here is the 3 pages of the questionnaire. We'll go through the checklist as we go through the slides, and then we may actually, if we have a little bit of time, we may come back to it and revisit it. So here's your deadlines. If you want to claim Medicare bad debts, you have to write those off by the end of the fiscal year. If your fiscal year end is 12/31/2020, then you need to write that off. And what a Medicare bad debt is, you've got Mark Lynn, who's a sorry Medicare patient who will not pay his copay or his deductible, and you try to collect for at least it was 120 days. You've sent from date of first bill. You sent out 3 or 4 statements. You've made a couple phone calls. You've treated me just like any other patient would as far as your collection procedures. You can write that off if there's been no activity, if I've not made any payments. So if I make a $1 payment, then you have to wait 120 days to write me off. So I'll be paying you $1 every 120 days to keep you from throwing you into bad debt. But if you do that, if you didn't collect that $1 payment, then you can write that off, but you have to write that off by the end of the year. If you send me this listing and everybody's written off in May of 2021, I'm not going to be able to put this on the 12/31/2020 cost report. I can put it on the 12/31/2021 cost report, but not this year. So if you want to claim Medicare bad debts, you only have that 21 days to get that, to write those off of your books. If you have an owner who gets a bonus that's accrued to them, you have 75 days to liquidate that after year end. And this comes into play when you have base year cost reports, when you're trying to push as much cost as you can into that little base year that Medicaid has. Then you have only 75 days to liquidate. And when I say liquidate, I mean write a check, cash a check, and put that in the owner's bank account. And then if we accrue a bonus or maybe retirement plan funding in a base year, you have 1 year from the fiscal year end. So in this case, it would be 12/31/2021. So you actually have 1 year to liquidate that. Signing up for the EIDM for the PSNR role and to make Dani the authorized cost report preparer for MCReF, that is 12/15/2020. We just, as soon as possible. That answer should be as soon as possible. If you don't have access to EIDM or you've lost it, then now is the time to get started, because it takes about 6 to 8 weeks to get everything done. Dani, you told me to remind people about something, and I've completely forgot. To add you as the PSNR person. Could you explain that to everybody?
Yeah, so if you have access to the EIDM, you have to keep your password updated. I think it's every 90 days. And a lot of times people forget. I actually have an account that I can request to be a PSNR user for your company. I am more than happy to send that request because I do keep my password updated. I can send you a request, but your security official will need to go in and approve me. And that will give me access to pull that PSNR for you. That way you don't have to stress too much if you forget to update your password in that 90-day time frame and you get locked out.
Yeah, and if you guys have lost your password or it's gone out of date to 90 days, you haven't updated every 90 days, we still have access to getting PSNRs pretty quickly and pretty easily as of now. We don't want you guys to depend on that. We want you to try to get this EIDM, especially with everything going to the portal, to the MCReF system in the future. You're gonna have to be a part of EIDM in order to do that. And like I said, right now, there's about 50,000 cost reports that are filed every year. And this program only opened up in 2018. And so far they've received 40,000 cost reports through the portal. So it's much easier in the long run if we can get these, if you guys can have this access to EIDM and allow us to be the authorized cost report preparer. It's going to make the workflow go a lot smoother for everybody, and it gives us a way to track stuff once it gets into Medicare as well. As far as getting your work papers to us and submitting everything through the portal that I talked about, we pushed up the deadline to 3/31/2000. Normally we put April 15th or so. We want you to get to us a little bit earlier this year because of all the different reporting issues that we have, especially related to productivity standards and maybe asking for a waiver because we got some issues with telehealth and we got issues with COVID and sick providers and all sorts of things like that that we have to sort of think about on this cost report submission. So we want to get a little bit earlier this year. Also, we want visits. If you think you've got a productivity standard problem, and we'll talk more in detail about it as we go through the webinar, then we want you to send your visit sheets and your provider FTE reports to us by 2/15. Again, that's not very long. I know that's only 45 days after year end, but we're going to have to submit a request for a waiver before the cost report is filed. So that's why we need it so early in the game. So there's MCReF, and again, you want to make Dani your MCReF approved cost report filer and the PSNR person as well. What we will do, this is sort of jumping to the very end. This is the great part. I always love doing these. That at the very end, we do your cost report. We'll put together a dashboard, and it will tell us the stuff in green says everything worked the way we thought it should. The stuff in red says, something went wrong here. This one, we didn't actually file this cost report in the previous year. They got $190 for a flu shot. We came in at 47. So I think that's a little bit more reasonable. Tentative settlements, we didn't get any during the year, which we thought that was sort of unusual. Usually you get some type of tentative or interim settlement. And then their interim rates for this particular clinic was $50. It was a CGS is the MAC, and they actually never did go in and change out the rate for them. So that's going to be our first recommendation was get that changed so that you should be getting at least $86.31 per visit. And then Medicare Bad Debts, they didn't claim any Medicare Bad Debts. So that's something. This is a way for us to just to make sure that we didn't screw something up, because as much as I like to say that we're perfect, we're not. And so this helps us to find issues when we're filing the cost reports. And we'll make a copy of it and send it to you in our final package that we send to you. So overview, the purpose of the cost report is basically to reconcile your payments. And I'll go through this basic stuff really quick because most of you have already seen it, and then we'll get to the newer stuff as soon as possible. So what is the Medicare cost report? Again, it's a Form 222. It covers typically a 12-month period of time. If you're brand new, one of the things that if you just got certified this year, your cost report period of time will start from the day you were certified as an RHC till the end of your fiscal year. So if you're 12/31 and maybe you were surveyed on June the 6th, your time period will be June 6th through 12/31. So keep that in mind, and we'll ask you for information for that period of time. Here's the official what a cost report is from the I think this is the PSNR FAQ, which is really, really good. So if you're having issues getting your PSNR, look at this FAQ here. This will really, really help you with that. And I'm not going to read that to you. There are about 50,000 Medicare cost reports filed every year. They account for $200 billion of reimbursement. What will happen to you if you do not file one of those is you are not going to get your portion of that $200 billion. So you need to, that's the reason why you need to make sure you file this cost report, because you ain't getting paid if you don't file this. So why is the cost report important? Dani, do you have something to say? I see your phone went back on.
Nope, I think I accidentally hit it.
Okay, all right, no problem. Okay, why is the cost report important? Number one is you're not going to get paid. That's probably the biggest thing. Number two is your rates from both Medicare and Medicaid in some states are based upon these cost reports. Especially if you have base year cost reports, it's going to be really important for you to talk to us or your cost report preparer and let them know you're in a base year, and that way, so you need to do a little bit of more planning in a base year, because it's a 1-year snapshot of your operation, and Medicaid will set your rate based upon that. So if you don't capture all of your expenses during that base year, you're never going to get a chance to get reimbursed for that. So that's why it's important. Also, you're going to receive a settlement for your flu, your pneumococcal, and in 2021 for your COVID-19 test as well. So flu, pneumococcal, your Medicare bad debts, that's 60, you'll get paid 65% of the bad debt that you write off. So you want to get that. Also, there's some money for preventive deductibles and co-pays in there as well. And then you are responsible for preparing this cost report accurately. We don't sign, you guys are going to be the one that signs for it. It's one of the reasons why we do so many seminars and so many webinars, trying to keep you guys aware of the rules and how to stay in compliance with the rules. We'll be filing, we do Medicare independent cost reports. We'll be filing a CMS 222-17 for you. If you're provider based, we don't file those. Those are hospital cost reports, but those will be the 255210, and your cost report preparer will be preparing that for you. Here are the forms that we will be completed on the independent side. The green side is what we'll be doing. And you probably don't, this is more information than you guys need to know. There are the rules. I think it's chapter 46 or chapter 29 of the provider reimbursement manual, and then chapter 46. I knew there's a 46 in there. There's where the instructions are for our RHC cost report. So you don't really need to know that, and there's the links to that. The reason why I've got all this stuff in here is I'm studying to be a certified cost report specialist, and my test is tomorrow. So I've been studying more. I know all the chapters now for all the different cost reports and things, which is useless information, but I have it. Here is the cap, $87.52 that just got increased just the other day. For 2020, your cap will be $86.31 per visit. Medicare will not pay that. Remember, they pay you 80% of that. And for a portion of the year, they only paid 78.4% of that because of sequestration. Remember, during the PHE, the 2% sequestration reduction will not apply. So I'm sort of curious how that's going to work out on the cost report. Hopefully they've updated the cost reports internally to not take that money away from you. Those are the Medicare basically settles four things. One is the difference between your interim and your final rate. And because the MACs are paying you more than the cap, that $86.31 cap we talked about, they're actually paying you more than that per visit in a lot of cases. Sometimes you've been having to pay money back to Medicare, and we'll explain in a lot more detail about that just in a minute. Your flu and pneumococcal shots are additional monies. Your Medicare bad debts are additional monies besides the rate, and then your copays end up being additional monies as well. Here is the problem. A few years ago, the MACs actually started paying you interim rates that were higher than the Medicare cap, and they also were paying you interim payments during the year. If you didn't report us those interim payments to us, we didn't report it on the cost report, and we would ask Medicare for more money back as a settlement than we should have, and then Medicare would pay you that tentative settlement without even looking at it. You get a tentative settlement, which would be too much. And then when Medicare would get around to doing what's called the NPR, they would look and say, oh, we paid those guys $36,000 and they never reported on the cost report. And we paid them a tentative settlement of another $40,000. So you end up having to pay back that money that was overpaid to you. So that's why we put together this work paper. This is a part of the checklist. Is we're asking you very clearly, we need to know if you got any interim lump sum payments. And in some cases, we've actually seen Medicare take money away from you. And so we need to know that as well, so you can get more money when we settle the cost report. But make sure that you fill out this form, make sure you take a good look to identify any interim payments so that whoever's preparing your cost report can put that on there. So we don't have this face come the time they settle up the NPR and you have to pay back money to them. So we don't want that. And here's what the letter will look like. We're going to pay you a lump sum of $36,798. And it says for which cost report it's effective for. It's up here, 12/31/2018 in this case. Notice this is an independent RHC. They changed our rate from $86.31 per visit to $96.38. So that's a lot more than what the maximum rate is. And that rate covers your Medicare bad debts, your pneumococcal and your influenza shots. And if they mess up on these calculations in any form or fashion, it can create these paybacks. And this is a reason why you have these paybacks. Number one is you didn't give any Medicare flu and pneumococcal. We have one client in Kansas, and I think they got bought by another clinic or another hospital, and they didn't do any flu and pneumococcal. They had to pay back 20 grand to Medicare, and the doctor couldn't understand why he's having to pay back 20 grand. It's like, well, they paid you in advance for flu and pneumococcal, and you never gave them. And so that was the reason for that. Also, sometimes they just set the rates too high. The MACs are brand new at doing this, and sometimes their calculations are a little bit wacky, and that causes you to have an overpayment and have to pay that back. Sometimes your Medicare visits increase substantially. I know we have a lot of clinics where they're start to doing nursing home visits, and their nursing home visits are all Medicare. And I've seen our Medicare visits shoot from $1,000 a year to $6,000 a year. Well, every time Medicare pays you that extra $10 for your flu and pneumococcal for those nursing home patients that you didn't give them to, that causes this potential for a payback. Also, 1 year they'll claim, sometimes people claim Medicare bad debts every other year. They just, because it's a hassle to do. There's this form that has 10 different columns in it you have to fill out, and they say, well, we just write everything off every other year. In that case, if you don't claim as many Medicare bad debts in 1 year than the others, that could create that could create a problem. And then, of course, what we just said before, interim settlements. You received an interim settlement and you didn't tell your cost report preparer, they have no way of knowing. You can't look it up in a PSNR or anything like that. It's not going to get reported, and that's going to cause you guys to have a payback. So in that fund. So, okay, now the different types of cost reports. And there's 3 types of cost reports. One is a no utilization, which is the funnest and easiest ones because you hardly do anything. That's great for pediatric practices if you're not in Tennessee. And most states, all the states that I know of except Tennessee, if you have no Medicare utilization, you're allowed to file a no utilization cost report with Medicaid. In Tennessee, TennCare requires all rural health clinics to file complete cost reports, full cost reports. So our Tennessee clients there, you're in this column here where yes, you have to do a cost report. Low utilization, if you have less than $50,000 worth of Medicare monies coming in each year, you can file a low utilization cost report. The problem with that is you're not going to get a settlement. If you give flu and pneumococcal shots, you're not going to get reimbursed for that. And Medicare Bad Debts, you're not going to get reimbursed for those. So it's a trade-off. It's how much money you want to pay the cost report preparer to do a full cost report. Would you get, and Danny and I do a little calculation, and that's why if you think you qualify for a low utilization cost report, send that to us in early and let us know. And that way we can do that calculation ahead of time before we go through and do all the work for you and then find out, oh, they qualified for a low utilization cost report. We could have done this for a lot cheaper fee instead of having to do all this work. And so if you think you're at less than 50,000 in Medicare utilization as far as money's paid, let us know very early on and we'll try to file this low utilization cost reports ahead of time. Danny tries to get those out the door by January the 31st of every year so we can get them off of our list of cost reports to do and then concentrate on the full cost reports where you will get a settlement, you will get your Medicare flu and pneumococcal money, and you will get your Medicare bad debt money as well. Here's the no utilization cost report. Again, Tennessee requires a full cost report. The no utilization, if you're a pediatric office, let us know early. We'll get those things filed early, and it's a very cheap fee to do that. Here's where we get the low utilization threshold for RHCs. It's 50,000. For other provider types, it's 200,000. So, and then here's what you have to do in order to file a low utilization cost report. You have to add an income statement. I think a balance sheet is on there. There's a particular type of letter you have to sign as well. And we do have to get in the cost reporting software and create this S worksheet for you guys to do as well. So there is some time and some money involved in those as well. So again, here's the reasons, the disadvantages to low utilization cost reports is you're not going to get any of these settlements, just like we talked about. Medicaid base year cost reports, again, each state is different, so you want to talk to who's preparing your cost report. If you think you're in your Medicaid base year, and usually it's the first full fiscal year that you've been a rural health clinic. So if you have that short period where you got in June the 6th of 2020 through 12/31/2020, that's not going to be your base year. Your base year is going to be January 1, 2021 through December 31st, 2021. That will be your base year. And so I know in Kentucky we have a sheet where we tell people, here's all the information you're going to need to keep up with because Myers and Stauffer is going to audit you to death. And so just talk to your cost report preparer and keep a close eye on your visits and your expenses during that year because it's going to be, you get one shot at this thing. So keep that in mind. Okay. Some more of the new stuff. COVID-19 may cause RHC providers to not meet productivity standards. Let's go into that. The productivity standards come from Chapter 13. A physician who works full-time should be seeing 4,200 visits, and a nurse practitioner and a PA should be seeing 2,100 visits. That's if you're working 40 hours a week, 52 weeks a year. That's what you should be doing. If you work less than that, then the numbers will be less than that. You're not a full-time 1.0 FTE. And so due to the impact of COVID-19, you may not be able to meet the productivity standards. The reason why your volume is down because of shutdowns. Telehealth medicine visits, starting in March of this last year, we were able, or this year, we've been able to do telehealth visits, and they pay that $92.03 from Medicare. Unfortunately, those visits don't count as an RHC visit when you compute your all-inclusive rate. So we're going to have to pull those visits out separately. We're going to have to keep up with our time and because it's not going to count as an FTE on our RHC cost report. And we're not going to count those visits in there as well. And we're not going to count that cost of doing those services. So if you don't meet that minimum productivity, we can request a waiver from the MAC. And and that's what we're going to talk about how to do it. There's your numbers there. Some of the basic information that you're going to need are, your clinic operating hours, the available hours and visits by provider, and then how much of a productivity exception do you want? I mean, the number for the physician is 4,200. What I've seen is people, maybe they ask for 3,000. We have an example of one like that just in a second. And then if WPS is your MAC, they will ask for a ton of documentation. We'll show you a picture of what they're asking for. So here's the information from Palmetto. That's 90% of our clients are Palmetto as far as the MAC goes. So they don't really provide a whole lot of information here. I'm sure this is dated 7/21/2020. I'm sure that they'll probably have an update very soon once the year is over. So that's for you Palmetto folks, hang on. WPS, they have a form here, so we don't have a whole lot of WPS clients, but just want to, this is the actual waiver request if you have WPS as your client. You'll notice that this waiver request has been available. Well, this is dated December 8, 2020, even before the pandemic. We've been able to request waivers for the productivity standard for the last 30 years. This is nothing new. It's just we've never needed it until the pandemic. So keep that in mind. What we've done is, and we've added this form here. We sort of took Judy Quinn's form and sort of modified it a little bit because we really have to get some good FTE calculations this year. And so we'll put your physician's numbers here, how many hours they work performing patient care, hours doing administrative cost, hours doing non-RHC activities, and then that gives your total work week, and then number of hours. It's a lot of information, but we're trying to get your number of FTEs on the cost report. And so, and the reason why, let's go here and show. So that's going to be one of the forms is going to be on our cost report, and then we're going to ask you guys to do a time study. And so if you haven't done a time study already, what we're looking for is how much time have you spent face-to-face with patients. That's what I call the green time. This is going to be the portion of your time that we can count as an FTE. Your administrative time, this is our yellow time here. These are things that will probably not be a part of your RHC patient care and will not be a part of your RHC FTE, but we need to know what that time is. And then your non-RHC time. These are things that aren't billed as RHC services. They're not a part of the all-inclusive rate. So your hospital, that's paid fee for service. If you have non-rural health clinic time, that's called private practice in the RHC cost report. That is not going to go in this green section. Telehealth, if you're doing telemedicine, do not count that time as patient face-to-face time for the cost reporting purposes. If you're doing chronic care management, again, that time is pulled out. So you can do basically go ahead and go home and start working on these time studies, and then maybe try to recreate a few of them. If you can go back in time and figure out what you were doing in March and April and May, at least give us an estimate of what you guys were doing that period of time. So, and here's just a summary. Clinic hours, treating patients face-to-face and charting, that will count as your as your RHC all-inclusive rate time. And if you're going to the nursing home and seeing patients, you want to count that time as well. So that's your green time. Here is all that red section that we talked about. Don't include this section over here as a part of your productivity of your all-inclusive rate calculation. So, because we're running out of time, we'll move through this quickly. Here's the example. When we do the cost report, we want to have an approved waiver already. So we can answer this question, yes. And then we can change, when we submitted this application, we asked for 3,000 to be the productivity standard for our physician and 1,000 for our nurse practitioner. And so it got approved, we answered yes, everything is good. Our rate per visit will not decrease because of that. So, okay, moving on. Visits, and we got 11 minutes before we get to 2 o'clock, so, or 1 o'clock your time. Why are visits so important? Do not count your telehealth visits in that all-inclusive rate calculation. That's why we've had to revise our cost reporting forms for you. Also, here's a big thing, is your Medicaid cost reports. I know in Kentucky, I know in Tennessee, when you're doing the Tennessee Medicaid cost report, it's going to be completely different because they're paying the all-inclusive rate. So we need to include those telehealth visits on our Medicaid cost report. So that's going to give us another layer of complexity when we do these cost reports. So look at your state and see how they're paying your telehealth visits, and that's going to change how you count your visits. For Medicare, do not count your telehealth visits as a part of that all-inclusive rate. So that's the big difference there. On counting visits, the best thing you can do is send us your CPT frequency report by provider, and we will count those for you. If you just insist on counting them yourself, that's perfectly fine. We have that form for you. Where is our form? Here is the new form. So if you click right here, you'll be able to print this off. It's a 5-page form, and this is basically face-to-face encounters here, not telehealth. So and then we'll go in here again, more CPT codes here. This is all face-to-face. And then what we've done here is this is the telehealth piece now. So these are for all of your telehealth visits. What you want to be careful is not to double count. If you do this G2025 code and you code the 99213 for the same thing, we don't want you to double count that. Just only include that once, because we're going to exclude some cost from the cost report. So keep that in mind. And then there's some more of the preventive services there as well that you can be doing via telehealth. And then finally, your ancillary services that are billed to Medicare Part B fee for service. If you're a independent RHC, all of your lab tests, you're going to bill those to Medicare Part B fee for service. We just want a total of those there, and then we can pull that cost out of the cost report. Venipuncture is actually an allowable expense on the cost report. So give us the number of venipunctures that you did. And then if you have radiology or any other technical components like your EKG that you bill to Medicare Part B, we want to know that number. We want to exclude it from the cost report as far as the cost goes, so we're not double dipping. And so that's why the purpose of that report is. Let's go back and see. And then here in section 40 of chapter 13, this is the definition of a visit. A medically necessary visit where it's face-to-face, a one-on-one encounter within the practitioner's scope of practice in the state they reside. So keep that in mind. That face-to-face is very important. It basically has to be at least a 99212. A 99211 is not a visit for RHC Medicare purposes. And you can have 99211s in rural health clinics. You just can't bill those to Medicare. So keep that in mind as well. And then this was added a couple years ago to the cost report where they want information by payer mix. So we've added this work paper in the cost report set for you guys, for you to tell us what the payer mix is. Now, we will always adjust your Medicare to the PSNR report, so that one is probably not as important. We don't have a good way of knowing your Medicaid, so do a good job in doing your Medicaid counts for us, and then your CHIP. And some people have a hard time coming with the CHIP numbers. They are hard to get a hold of, and I don't have a good answer yet on how to get the CHIP numbers. And then that's just the difference between your Medicare and Medicaid, basically. But we need that information. Flu and pneumococcal shots. Basically, probably the easiest thing to do is look at, this is the log that's in your work paper set. We want your RHC name, the CCN number, the fiscal year, put the patient name here, their full name, their MBI number, and the date you gave them the shot. And then basically, if you just put the page, when I say page number, page number 1, page total, that was going to be 20, and then a total. The total Medicare flu shots, that's going to be, in this case, it'll be 20. If you have 10 pages of these, then it's going to be 200 there. So we're just trying to keep a running total, so it makes it easier for us to audit these things as we go through and put these numbers on the cost report. So there's your Medicare influenza log. Here's your pneumococcal log. And then here's your COVID-19 log for next year whenever you start doing the vaccine. The vaccine will not cost you anything, but you will get reimbursed for your time administering this. So that's basically what we need, except for invoices. We do need your invoices on how much you paid for the influenza and pneumococcal shots. We have to support that when we submit this to Medicare. So give us that so we can tell them how much you paid for that. We don't need a log for non-Medicare patients, but we do need to know how many flu and pneumococcal shots you gave so that we can put that in the cost report as well. Okay, EIDM, remember, start early. One of the biggest mistakes that people make is they don't have a backup security officer. A lot of times the office manager is the security officer. She or he resigns and nobody knows, and there's not a backup security officer, and you lose access to EIDM. So you want to make sure you have a backup officer and then get Dani involved to be able to pull your PSNR. Here's what the PSNR website looks like. They do change the password. It says 60 days here. Dani said 90. I'm not sure which one it is, but you have to change that password pretty often. Here is the portal that you can go in to get into EIDM. We want you to ask for a summary report. Do not ask for a detailed report. If they ask you for an address to send a CD-ROM, you're headed down the wrong path. You want to ask for a 710 and a 71S summary, and they'll send it to you via email. There's no PHI in it, and it will give you it'll be like 2 or 3 pages long. So it'll be very easy. Here's what one looks like. I mean, there's not a lot of information in there, but it's information we need to accurately file the cost report. Okay, we're getting close here. What are we on here? Oh, I may make this in 1 hour yet. Medicare bad debt is 65% of uncollectible Medicare copays and deductibles. And Julie Quinn did a great job on, she did a presentation for bad debt a few years ago in Alabama. So there's a whole presentation on bad debts because we're running out of time. So here's what describes what a bad debt is. It is a copay or deductible that's on the Medicare Part A remittance advice. If you bill something to Medicare Part B, your hospital stuff that you bill to Part B fee for service, you cannot include that. And this is only Medicare, so no Medicaid, none as far as that. If Medicaid is primary, then you can include Medicare. We're really talking about Medicare is primary for this. So that's what a Medicare bad debt is. There's something called a crossover. When I started stumbling because of Medicaid, when Medicare is primary and Medicaid is secondary, if Medicaid does not pay you the full copay and deductible like they should, then you can claim that as a dual eligible and get reimbursed for that lost reimbursement as well. So that is something you want to look at. So Medicare copay is at 20% of charges. I should have updated this. Medicare deductible in 2021 is going to be $203. So that deductible is going to be way up there. So it's a good idea to keep up with your Medicare bad debts if people don't pay that $203. It has to be billed to Medicare Part A. No Medicare Advantage plans or replacement plans can be included here. Same thing on your Medicare Influenza and Pneumococcal logs. Medicare Advantage plans do not go on those logs as well. Let's go on here. You must cease your collection efforts. If you turn it over to a collection agency, you haven't given up trying to collect that money from that sorry Mark Lynn. So keep that in mind, is you have to cease all collection efforts and write it off in order for you to claim it. And those are the rules from the Federal Register. Use an Excel spreadsheet to keep up with this. That's the best way to do that. And we have an Excel spreadsheet for you guys to do that. Keep your crossover and your regular bad debts in separate Excel spreadsheets. That's very helpful. This is a form. This is the government form. It's called Exhibit 2. You see it's got 10 columns in it, and this is an Excel spreadsheet. So if you click here, you'll be able to go into that. This is, I love this. The Paperwork Reduction Act, 11/10/2020. This is draft format. This is not finalized, but they're gonna, in the Paperwork Reduction Act, they're actually going to move our number of columns from 10 to 25. And so don't worry about this yet. This is coming down the road. And hopefully we can stop this from happening. But this is a lot of information. They're going to ask us even more for bad debts. It's hard enough already getting your bad debts already. So keep that in mind. There's your crossover dual eligible bad debts. There's the Excel spreadsheets for you guys to get your hands on. There's also a policy for the cost report for your bad debt policy. You don't have a Medicare bad debt policy. You have our collection policy. You have a collection policy because you treat everybody the same. Finally, electronic filing of cost reports. The main thing you need to know about that is get into EIDM and get Dani set up to be your authorized cost report preparer. From that standpoint, if you'll do that, we'll be able to do all this. It's not required. I mean, that is one of the key things there. If you don't want to do it, it's not required. So keep that in mind. There's the actual login location for it. There's authorized person. Okay, wow, I made it in. I was only 1 minute longer than what I thought I would be. Dani, do we have questions out there from?
Yeah, you got a couple.
Okay.
The first one is, if you send a Medicare patient to collections for their coinsurance, and then you pull it from the collection, do you pull it from the collection company when you report it on your cost report as bad debt?
Okay.
Do I need to reread that?
Yeah, I gotta say I'm hearing it, but it's not coming through. Let's say it one more time.
Okay, if you send a Medicare patient to collections for their coinsurance,
yeah, okay,
do you then pull it from the collection company when you report it as bad debt?
Yeah, absolutely. You want, if you're trying to collect that money and it's still at the collection agency, you're still trying to collect it. You've not written that off, so you have to pull it back from the collection agency. Okay.
The other one I got, where are all these log forms? I'm assuming it's, he's asking for like the checklist information.
It's all on the website at RHC cost reporting, Rural Health Clinic, ruralhealthclinic.com cost reporting. All these materials are on there for you guys. So you can just click in there, and then the PDF of this presentation is on there. And so all the stuff is right there, or some of the logs as well. Okay, next question.
And I'm reading through to make sure I understand.
Yeah. And if you will, if you have a question, you can raise your hand. I see Alicia's got her hand up. So Alicia, let me open up your line real quick, and let's see if Alicia. Okay, self-muted and muted by the organizer. Okay, now you're self-muted. Alicia, do you have a question? Probably had to go back to see patients. Alicia's a nurse practitioner over in West Tennessee. Okay, Alicia. Okay, if you do have a question, you guys can raise your hand and I'll open up your line for you.
Mark, the other one, if Medicaid does not pay at all or cannot get them to pay, for example, time limit expired, even though you sent 7 times to Medicaid, is it still considered bad debt?
There should be, they sent it 7 times to Medicaid. It depends on what the denied, there's not a yes or no answer on that. It will depend on what the denial is for. If they weren't covered by Medicaid, then no, it's not going to count. Timely filing, I don't think it's going to count too. That one's going to be, unless typically the ones you can claim are the ones that were actually paid, and maybe the copay was $30 and Medicaid paid you 13 or 14. That difference you'll be able to put in there. But if you send them a claim and they pay 0 and it's denied for some reason, 99% of the time, you're not going to be able to claim that as a Medicare bad debt.
Okay, he said that makes sense.
Yeah.
Can we use provider relief funds for payroll purposes after PPP is used up?
Yes, you can. Yes, you can.
And that is all I've got so far.
Okay, oh wow, not many questions. Okay, great. All right, well, thank you everybody for being here today. We had a bunch of folks here. We had like 100, we had over 200 sign up and over 160, 170 at one time. So thank you very much. We appreciate what you guys are doing. Stay safe. I know it's extremely dangerous out there, and hopefully this vaccine will help us get through this and we can get back on the road again seeing you guys. So thank y'all. You have a great holiday season and we will talk to you soon.